to civil registration and vital statistics. That means anything under the roof we are trying to cover. All public health related activities and the scope of the work is covered under comprehensive public health services. And the whole Medical Academy of India, ever since its inception, has been conducting several seminars in general medicine, particularly on diseases like diabetes, cardiological diseases, hypertension, lipids, obesity, and various other allied disciplines, and thereby improve medical knowledge to medical practitioners and specialists. We also arrange for research in internal medicine and related specialties and run institutions in furtherance of the trust. The motive is also to educate the public on the prevention diseases for maintenance of good and sound health. For this particular webinar series, as you know, we have a series of 5 and today is the 3rd lecture on it. So today's lecture is basically to promote the standardized care for hypertension that is evidence-based and aligned with international best practices. I would like to stress here, many a times we always feel that the guidelines are there as rules, but guidelines are only to guide us and they are not actually rules. So today's focus of the virtual workshop would be to promote standardized care for hypertension based on the most recent WHO hypertension treatment guidelines of 2021. Also to promote opportunistic screening of all patients over the age of 18 and do away with the myth that it is only after 40 that you will have hypertension. To reduce the physician inertia, which is a major roadblock to start, and as well to continue the treatment of hypertension, and to emphasize the importance of medication titration, whether it is up titration or down titration, and the follow-up of hypertensive patients to ensure the best of the control of blood pressure that we can get. Next, sir.
Yeah.
So as I was saying that we have a list of 5 webinars and those who attend all 5 will get a participation certificate from World Lung Foundation South Asia and Hold Medical Academy of India. Also, Tamil Nadu Medical Council has credited it with the credit points. So today's webinar is on simplified protocols for hypertension treatment. And we are actually blessed to have a speaker like Dr. A. Muruganathan and a panelist like Dr. Sangram Biradar. To speak a little more, we go to the next slide. So after we have the talk, we will also take the quiz program. So those of you who've been with us for the last few webinars, you are well aware of it. For those who are new, you have to type kahoot.in in your laptop or mobile. Once we are ready, we give you a game pin number. You will enter the pin and your name, and then you will enter the quiz. There will be 15 questions, and for each question, there are options given, and then you have to answer those options. There's a timer, and so all that we do after the lecture is over. And those who give correct answer early will get more marks. It's a leaderboard which keeps giving us the ranking, and the top 3 podium winners are given BP monitors. So this we will also be doing after the talk. So today, as I said, for today's program, we are the 3 who are there today. Dr. A. Muruganathan, physician speaker for today. I am Dr. Vidita Khandelwal, the moderator, and Dr. Sangram Biradar is the panelist. Though Dr. Sir, I would like to introduce you.
Not necessary.
Not necessary. I know Dr. Muruganathan doesn't require any introduction, and maybe it's like showing what you say, a candle to the sun. So I won't read it out. I am Dr. Khandelwal. I would just introduce myself as Directorate of Research of Sikkim Manipal University and Professor and ex-HOD of Medicine at Sikkim Manipal Institute of Medical Sciences. And we have an expert panelist with us. Next, sir. Dr. Sangram S. Biradar. He is the Professor of Medicine at MR Medical College, Gulbarga, Karnataka. Most of you know him. Sir is also a consultant physician at Basaveshwar Hospital and SB Medical Center, Gulbarga. He is an associate editor at APIK Journal of APIK Journal, Karnataka. He is also the governing body member at National API and the vice president at CSI Karnataka and vice president at API Karnataka.
That's it.
Yeah. The next webinar will be on 13th of September, which would be on difficult to treat hypertension. We'll again have Dr. Muruganathan speaking on it, with Dr. Panda as the moderator and Dr. R. Rajshekhar as the panelist. So today, as we are ready to begin with, just two more sentences from my side. Very often we find that we are so confused with the various protocols which are available with us. We find ourselves in a sea because what is written in the book, and when you actually get a patient in front of you, you realize that no, it doesn't match with the textbook picture. So in order to bring us out of that sea of confusion, we have an expert speaker today who would be speaking on simplified protocols for hypertension treatment. And not standing between you and the talk, over to you, sir.
Thank you, Dr. Vidita. Thank you, my brother Sangram brother and my good brother Rajshekhar, and all my brothers and sisters who are joined webinar. Of course, all of you know, it's just to hypertension, a silent killer, can affect brain, arteries, heart, kidney. It's again a triple paradox. Hypertension is very easy to diagnose, but often remains undetected. Simple to treat, but often remains untreated. Despite availability of potent drugs, but often treatment with all is ineffective. The high blood pressure is the world's leading killer. High blood pressure kills nearly as many people worldwide each year as all infectious disease combined. You can see 9.4 million deaths. Acute respiratory infection, diarrheal disease, AIDS, diabetes, all put together hypertension. So that is why we have to focus on hypertension. If you control hypertension, you can save most lives. You can see the number of deaths due to various diseases, hypertension, the number one. So treatment of hypertension among adults in primary care can save more lives. So that's very important. See, you can treat hypertension in the primary care and prevent our complications so that deaths and disabilities can be reduced. Deaths due to hypertension are largely preventable in comparison to other evidence-based interventions for non-communicable disease. Control of hypertension has the largest potential to save lives. That is why Resolve to Save Lives, takes this initiative. And if you see the global control also, people 1.4 billion, only awareness is 734 million, treated 489, and control 192, less than 14%. So even the global area, if you see, less than 1 in 7 with hypertension worldwide have under control. What about India? In burden in India, so we have 1.3 billion, and estimated number of hypertension patients is more than 200 million, and blood pressure control rate is less than 10%. And the government of India target is 25% of the relative reduction in prevalence of raised BP by 2025. The prevalence is 28.5, and awareness is only 27. And this is the statistics where the Indian Hypertension Control Initiative have started their project in very many states, and people who are on treatment, the control rate is 44%. So we have started a pilot project in many districts. Now we have extended to more than 100 to 200 districts in the country. And the people who are on the drug and treatment in the simplified protocols, which we are doing, 44% under control. So these simplified protocols we are implementing in various states, which I'm going to talk to you later. So we get a very good result of control by using the simplified protocols and some system placed in the various states. The reports from World Health Organization, Global Burden Disease, and UK-based NCD risk have highlighted that hypertension is the most important cause of mortality and morbidity in India. Proper control of hypertension could easily prevent more than 30% of the estimated 1.5 million deaths attributed to hypertension in India. And of course, every time we are not fed up talking about how to measure accurately, use validated instrument with right technique to measure BP. It is important for screening, diagnosis, and monitoring. Now, whenever you talk about hypertension, we have to have the framework of anti-hypertensive medication treatment. Analytic framework. What do you do? First, what BP level should pharmacological therapy be initiated? Are lab tests needed before to start therapy? Is risk assessment needed to start therapy? Is it monotherapy or no therapy? Or lifestyle modification? Monotherapy versus other monotherapy. Monotherapy versus combination therapy. What choice of combination? Single pill combine or pre-combination? What is the post-treatment target BP level? And after that, when should BP be reassessed after treatment initiation? Management physicians versus non-physicians provider. Okay. Now, what are the factors that contribute to uncontrolled hypertension? Overall, if you see non-adherence to prescribed treatment, multiple mechanism of hypertension pathogenesis, and therapeutic failure with monotherapy, dose titration, underuse of drug and drug combination strategy. Now coming to the evidence-based protocols for hypertension management. This is the World Health Heart Package, HBITS Healthy Lifestyle, evidence-based protocol. A means access to essential medications, team-based care, systems for monitoring. This is the heart package introduced by WHO. Why you use treatment protocol? The best health system use standardized treatment protocol to improve quality. Example, Kaiser Permanente, US Veteran Administration, etc. Simpler protocols are more likely to be used correctly and more likely to result in higher quality care in any country. Practical treatment protocols can increase the rates of hypertension control by reducing treatment costs, facilitating team-based care, improves supply chains reliability, facilitates large volume purchases, logistics, training, supervision, evaluation, and overall program implementation, and increases the impact of treatment programs. See, if you do a statewide protocol, and if all the states are doing only same protocol, easy to purchase the medicines, and you can do logistics, training, supervision, etc. It reduces unwarranted clinical variability, inappropriate therapeutic inertia, enables the healthcare team to advance patients safely and efficiently along the treatment pathway. It can actually incorporate into electronic health records through clinical decision support tools, registry, which is not there. Now we have to, by implementing these simplified protocols, we can have a nice registry functions. Many similar treatment protocols are acceptable options depending on local prescribing experience and health system capacity. We don't insist all the states should start only the same protocol. According to your convenience, according to the drug availability, according to your culture, you can use your system. Specific regimen chosen is less important as long as blood pressure is controlled. All-cause death rates are reduced. So streamlined care, simplified drug procurement, and improved patient adherence is all due to protocols follow. What is the difference between a protocol and a guideline? Vidita was talking about guideline. The scope is specific for local setting. Protocol can be district level, state level, hospital level. Guidelines is summary of the evidence-based practice issued by the professional bodies like Indian Hypertension Society or American Heart Society Association or European Heart Society or International Hypertension Society. Complexity of protocol is very low, it's high. The protocol is just one page. Here it is 50 to 500 pages. Specificity, more specific information such as drug name and dose. Here they'll give many drug classes and drug options. Dose titration with a specific drug dose is given. Overall titration approach. Use in primary care, very important, easy to understand, implement at primary care level. That is why simplified protocols is very good because many patients are treated at the primary care level. These guidelines are better understood by experts, especially now so many guidelines have come, more confusing. So public health contacts easy to implement in the protocol and it's challenging. So that is the difference between protocol and guidelines. Coming to antihypertensive drugs, the first line drug. Long-acting antihypertensives are preferred as a first-line drug. Any one of the following three classes. One is long-acting dihydropyridine calcium channel blocker (CCB), angiotensin converting enzyme inhibitors, angiotensin receptor blockers, thiazides and thiazide-like agents. Combination therapy preferred, preferably with a single pill combination to improve adherence and persistence as initial treatment. Nowadays we talk about combination therapy, that too single pill combination, SPC. Now, diuretics as a first-line treatment, calcium channel blocker as a first-line treatment, ACE and ARB as a first-line treatment, ACE, ARB, CCB as first-line treatment, CCB diuretic as first-line treatment, ACE and ARB and plus diuretic as first-line treatment. So, depending on your state or your conditions, your state or your hospital, you can choose any drug. Normally, I'll tell you the protocols what we follow in our Indian states. In UK and Western countries, they may start with ACE inhibitor like lisinopril and then add on drugs. Here is different. So what are the strategies we adopt? Even in your private practice, you can start like this. You should start one drug, titrate to maximum dose, and then add a second drug. This is one way. Suppose we are starting amlodipine. You give amlodipine 5 milligram, then second visit, if there is no improvement, 10 milligram, and then add another drug. The second strategy is strategy B. You start one drug, let's say amlodipine 5 milligram, then add telmisartan 40 milligram before you achieve the 10 milligram dose of amlodipine. Then third strategy or C strategy, begin always with two drugs at the same time, even in the first visit, either as a two separate pills or a single pill combination. And then this is the WHO guideline for the pharmacological treatment of the adults. Whatever I said, algorithm of 1 is telmisartan with amlodipine 5 milligram, increase telmisartan to 80 and then amlodipine 10, and telmisartan 80 amlodipine plus add hydrochlorothiazide, or telmisartan amlodipine increase hydrochlorothiazide 25. This is algorithm 1. Algorithm 2, amlodipine 5, make it amlodipine 10, then add telmisartan 40, then add telmisartan 80, and then add hydrochlorothiazide. So the strategy is like this. Also, I told you, you can always have fixed drug combination also. Nowadays, they talk about fixed drug combination, single pill combination, SPC. Now, this is what we do. Normally, when somebody comes amlodipine 5 milligram, then make amlodipine 10, then add telmisartan 40, telmisartan 80, hydrochlorothiazide 12.5, then 25, or chlorthalidone 12.5. And then, if even if it is not controlled, then you refer them to specialists. Don't forget, before you initiate all these things, you will have to do certain investigation, also lifestyle modification, and you have to have validated BP monitors. Proper follow-up is very important. And these are the protocols I told you. Amlodipine 5, 10, 40, 80, 12.5, chlorthalidone 12.25. This is one type of protocol. The other type is 5 milligram of amlodipine. Second visit, you give 40 milligram. Third visit, you add 80 milligram. Only fourth visit, you add 10 milligram of amlodipine along with this. And chlorthalidone 12.5 and then 25. So this is the Indian Hypertensive Control Initiative. We give different protocols. What we do, the experts, Indian Hypertension Control Initiative is launched with the joint venture of state government, central government, ICMR, WHO, Resolve to Save Lives. I am one of the consultants for IHCE. What we do, we go to every state, call the experts, call the professors of medicine. If I go to Gangtok, I'll call Vidita to come. If I go to Gulbarga, I may call Sangram. Here, we all discuss what is good for that particular state. So we'll start with one drug and then add two drugs, and then like this, we'll develop a protocol. I'll show you. This is the Telangana protocol. The protocol was prepared through an extensive consultation with the local people, where whenever anybody has got 18 years above, if the blood pressure is more than 140, you start lifestyle modification, observe them for some time, and then prescribe amlodipine 5 milligram. If still not under control, then add amlodipine 10 milligram, then telmisartan 40, telmisartan 80, and then 12.5 chlorthalidone and 25. To check the patient has been taking drugs regularly and correctly. If this is the case, refer the patient specific to the specialist. So this is the Telangana protocol. This is the Punjab protocol. Punjab protocol is amlodipine 5, again amlodipine 10, telmisartan 40, 80, 12.5, 25. Drug and dose specific hypertension treatment protocol, 6 steps in protocol guided progressive. Availability of antihypertensive. See, most important in the public health sector, whatever drug you give, all the 365 days, the drug supplying chain should be good. It's not like this. Suppose somebody comes today, you give telmisartan, tomorrow you give losartan. No. The same drug supply for the 365 days. Enable forecasting, simplify the procurement process, and decrease the medication unit cost. Then protocols why? CCB is in the protocol. CCB amlodipine is recommended as a 5 milligram tablet because most frequently used antihypertensive medication in many low and middle income countries, because of its low rate of serious adverse events, lack of impact on potassium levels. You don't need to do any investigation if you are putting on a patient with calcium channel blocker, because there's no potassium impact. Local healthcare providers are familiar with this class of medication, reduce need for laboratory testing. It can be taken once daily, available in a low-cost generic form, studied in clinical outcome trials, and can be split in half tablet as 2.5 or 1 tablet or 2 tablets. It is a scorable tablet, so you can start even with 2.5 milligram. One disadvantage of amlodipine is that 10 milligram per day, 25% of the patients may have fetal edema. Although not a serious adverse effect, it increases the rate of treatment discontinuation. Somebody gets fetal edema, even if you convince them it's not to be worried, but they will discontinue. So adherence is not there. So this can be mitigated by dose reduction or by adding RAS inhibitor. When you add ACE or ARB with amlodipine, the fetal edema is mitigated. Why ARB? The ARB telmisartan, the low rate of adverse effects and long duration of action once daily dosing. Again, low cost generic form, favorable experience in clinical outcome trials, and convenient dosing as I told you in amlodipine. It can be also half tablet 20 milligram, 1 tablet 40 milligram, or 2 tablets of 80 milligram. When used in combination with CCB or a diuretic, it is appropriate for all races, but it should not be used for women who may become pregnant. That is very important. In a reproductive age, when you give ACE or ARB, you must be very careful. ACE or ARB definitely can reduce fetal edema of CCB when used simultaneously. ACE are better documented to reduce cardiovascular events than ARBs, but ARBs are recommended due to much lower incidence of cough, angioedema, particularly in darker skin patients. And then a word about telmisartan. Telmisartan has got a dual pathway, that is PPAR gamma is the central regulator of insulin and glucose metabolism, improving insulin sensitivity. Telmisartan stimulates PPAR gamma activity independent of their AT1 receptor blocking action. Telmisartan lowers serum levels of glucose, insulin, triglycerides, and body weight. So it's a good drug in a diabetic hypertension. Any once daily ARB, irbesartan, candesartan, olmesartan, or valsartan, all of which are available in generic formulation, or once daily ACE inhibitor, example lisinopril, can be substituted for telmisartan. I told you in UK and all, they use lisinopril as the first line drug. Therapy with RAS inhibitors can cause hyperkalemia, especially among patients with reduced kidney function, and therefore periodical laboratory testing is advised. Why chlorthalidone? The diuretic chlorthalidone has long duration of action, once daily, low-cost generic form. It has been documented to reduce cardiovascular events and mortality. It has got polyactivity, a reluctance to prescribe diuretics in many countries, the risk of hypokalemia with limited access to routine monitoring of serum potassium and inconsistent availability of potassium supplementation is not recommended as the initial treatment step in many countries. But both protocols recommend referral to specialists if blood pressure is not controlled by combination of amlodipine 10, telmisartan 18, and chlorthalidone 12.5 or chlorthalidone 25. Some countries give up to 25 milligram of chlorthalidone before they refer to the specialist. Particularly if monitoring for serum potassium levels and management of hypoglycemia can be done in a primary care, they can go up to 25 milligram. A suitable alternative to chlorthalidone is indapamide 1.25 milligram. But if it is unavailable or costly, you can choose 25 milligram of hydrochlorothiazide. These are the pharmacological properties of three drugs: amlodipine, vasodilatation, decrease peripheral vascular resistance, reduce BP. Again, telmisartan, AT1 receptor blocker, vasodilatation, reduce PVR, BP. And chlorthalidone, kidney and vessels, initial diuresis, first only diuresis, then later on vasodilatation, reduce plasma volume, reduce peripheral vascular resistance, and reduce BP. And again, the maximum in 1 hour, this is 0.5 to 1 hour, and amlodipine 6 to 2 hours, 12 hours. Bioavailability 65, 42, and 64 to 90. Protein binding 75, 99.5, 93. Off-life, very important, 40 to 60 hours, 24 hours, amlodipine. These three are long-acting diuretics. Long-acting antihypertensives. That's very important because whenever you give any drug, you should have 24 hours action. Otherwise, the patient will develop control in the daytime, and nighttime you may have nocturnal hypertension. So elimination, major portion of the drug is excreted by kidney, chlorothalidone. 97% eliminated unchanged in the feces via biliary section, telmisartan, and 60% of the metabolites excreted in the urine, amlodipine. This is the recommended treatment protocols to improve management of hypertension globally, a statement by Resolve to Save Lives and the World Hypertension League. Fortunately, I was also one of the authors where we talked about policy statement from WHL Simplified protocols, which is circulated all over the world. And then WHO guidelines, just for completion, we follow WHO guidelines in the public health sector in 2021. Recommendation of blood pressure threshold, all of you know, initiation when the blood pressure is more than 140 or diastolic more than 90. Anti-hypertension treatment, the cardiovascular disease you have 130 to 139. If you have anybody with cardiovascular disease, diabetes, chronic kidney disease, you start the treatment around 130 to 139. Lab testing, if you can do screen for comorbidities, secondary hypertension, but only when testing does not delay, impedes starting treatment. So if you are taking time to do the blood test or investigation, straight away you should start. You should not delay the treatment. Recommendation of cardiovascular assessment, if possible, you can do where there is possible and does not delay. Recommendation, as I already told you, thiazide-like agents, ACE/ARB, long-acting CCB. And the recommendation on combination therapy, now WHO guidelines and all the other guidelines talk about combination therapy, preferably with a single pill combination, as I told you, SPC, as an initial treatment, preferably with a single pill combination to improve adherence and persistence as an initial treatment. Antihypertensive medications used in combination therapy should be chosen from the following drug classes. I already told you, drugs ACE, ARB, and CCB. Recommendations on target blood pressure. Target blood pressure treatment goal is less than 140/90 in all patients without comorbidity. Systolic target will be less than 130 in patients with cardiovascular disease. And then again, goal is less than 130 in high-risk patients with diabetes, kidney disease, etc. Frequency of visit recommendation, monthly follow-up till after initiation, till you get the normal pressure or controlled pressure. Change in antihypertensive medication until patient reach target. And you have to follow up every 3 to 6 months for patients whose blood pressure is under control. So once it's controlled, they can come after 3 to 6 months only. And recommendation treatment by non-physician professionals that we normally don't do. And hypertension treatment is essential even if the patient is asymptomatic to prevent target organ damage. I told you hypertension is a silent killer. So if you identify or diagnose hypertension, even if the patient is asymptomatic, start the treatment. And you prevent risk factors, tobacco, lack of exercise, high salt consumption. High salt consumption, last week we spoke elaborately on high salt consumption and overweight, etc. And one more thing you must not forget is sleep. You should have good sleep as a lifestyle modification because most of us don't attend to the good sleep pattern. Initiation of pharmacological treatment should start no later than 4 weeks following diagnosis. Proper follow-up through messages and phone calls. Even in the private sector, you should make sure you send the WhatsApp message, you send the phone call. Nowadays everybody is very good in phone call and WhatsApp message. Yesterday I received a WhatsApp message from a ready-made shop that your daughter's birthday is coming, so why don't you come? So everybody is now following up with social media and messages. I told you cardiovascular risk assessment after the initiation of pharmacological treatment for hypertension, but only where feasible and does not delay, you can do cardiovascular risk assessment. And according to WHO CVD risk assessment chart, those with CVD risk of more than 10 should also begin pharmacological anti-hypertension treatment. And specific hypertension medicine, of course, pregnancy, I already told you should avoid ACE and ARB. Beta blockers are not recommended as a first-line therapy, but if you have a cardiac problem or angina or heart failure, beta blocker can be started. Especially in India, we use beta blocker because our sympathetic overactivity, if you calculate, if you see, is the heart rate also in Indian heart study more than 83. So we do still beta blocker as a first-line drug in some patients. And barriers to hypertension management, it be behavior at the provider's level, the clinical guideline adherence, behavior at the patient level, no awareness, lifestyle not there, not follow-up. And all these things can be tackled with good knowledge, skills, and then motivation and the health system barriers. All these things can, as a teamwork, you should do. Hypertension management is a teamwork, and anti-hypertension drugs preference in the private health sector. You see, anti-hypertension drug market in India, total volume of sales in type of formulation drug class. If you see the 3-drug combination is very minimal. Of course, they do 2 drugs. Single drug is maximum. CCB is there. So India has the high burden of hypertension. Private sector provides 70% of the outpatient care in the country. A significant proportion of the patients seeking care from the public also buy from private market. They may go to hospital, government hospital, but with the prescription they buy from the private. Dissemination uptake of standardized hypertension guidelines in the public and private sector can improve the quality of hypertension care and help consolidate the market, leading to lower prices of recommended drugs. Suppose if all of us, all the private practitioners, also follow the simplified protocols, the volume of prescription of drugs will be more, and it can come to less price. See, as you see, when some drug is introduced, the drug cost is very much. But as the drug is more and more useful, and more people buy, it becomes cheaper. Like dapagliflozin. So like that, so many drugs when they come in the initial stage, it may be costly. But if all of us use and volume is more, it becomes cheaper. Procurement of drugs in India's public sector varies from state to state, and it's usually based on the national or state essential drug list. Amlodipine, atenolol, losartan, and enalapril were the commonly procured anti-hypertensive drugs in the public sector, but their volume of procurement is not available in the public domain. Though the private anti-hypertensive drug market seems massive, another study based on the same data set showed that there is a significant unmet need of hypertension treatment, with only 21% of the estimated hypertensive adults in the country receiving drug treatment private market. So this is a study done by the Resolve to Save Lives in the public market and the public health sector and the private market. So 21.5% of the patients only buy medicines. So now coming to I have talked about simplified protocol, but without knowing why combination therapy is useful. So I'm going to talk for another 10 minutes about benefits of combination therapy. The drive home message for all of you, now combination therapy is the key. But even in the diabetes, people have started combination therapy. The hypertension, I'll come to one by one why we start combination therapy. The era of monotherapy for BP control is over, and we have rightfully entered the new era of double drug or triple drug combination antihypertensive drug therapy to reduce the global burden of the cardiovascular disease. Now let us say you have uncontrolled blood pressure. You are giving amlodipine 5 milligrams. You increase the dose to 10 milligrams. What happens? The side effects are more. The edema is more, or some problem is there. So because of the side effects, people stop the treatment. So non-adherence to therapy, and again the disease cycle, uncontrolled blood pressure. So that is why monotherapy has got this problem. The primary hemodynamic parameters for BP regulations are intravascular volume, cardiac output, and systemic vascular resistance. This is the pathogenesis. The renin-angiotensin-aldosterone system, the sympathetic nervous system are the fine tuners that continuously both regulate and calibrate these parameters. And you can see kidney, natriuretic peptide, endothelium, sympathetic nervous system, all these things play a role. It's a multifactorial for a hypertension. That is why there is no simple way of predicting which patients will respond to which class of antihypertensive drugs. That's why always a combination from two different actions, two different classes, always better. Now you can see better BP reduction, component drugs act on different physiological systems. Lesser side effects. For example, if you give diuretic and ARB, the diuretic produces hypokalemia, whereas ARBs produce hyperkalemia. So it neutralizes. So they reduce the incidence of hypokalemia when you use diuretic with ARB. I told you CCB and ARB, CCB can produce edema, whereas ARB reduce the incidence of edema. So that is a combination there. And if you see CCBs produce only arterial vasodilation, whereas ARBs produce a decreased vascular volume, also produce both arterial venous dilatation. So that's why there is no edema. Combination of ROS inhibitors and CCB reduces proteinuria in patients with diabetic nephropathy, slows progression of renal disease. So fixed dose combination also improve patient compliance, resulting in more consistent, cost-effective hypertension management with favorable adverse event profile. Now I told you diuretics. For example, when you give diuretics, initially reduce intravascular volume. When you get intravascular volume reduced, that activates RAS, leading to vasoconstriction as well as salt and water retention. Initial phase. What does RAS blocker do? They produce the counter-regulatory response is attenuated. The counter-regulatory response, when you give RAS inhibitor, it's attenuated. So what happens? The addition of RAS inhibitor to a thiazide type of diuretic also improves the safety profile by ameliorating diuretic-induced side effects such as hypokalemia, which I explained earlier. And if you see diuretics alone, diuretics ARB. Diuretics causes hypokalemia, increased glucose, increased uric acid. ARBs cause increased potassium, decreased glucose, and uric acid. So when combined, the side effects are mitigated. So that is the importance and significance of combination. Combining anti-inflammatory agents from two different classes always result in 5-fold greater BP reduction with respect to doubling the dose of a single agent. Suppose, for example, you are giving, let us say, ACE inhibitor, and you double the dose, the effect is not there. Good. If you add a calcium channel blocker, it's 5 times more than doubling the dose. So combination of anti-hypertensive agents, low doses, besides its higher efficacy, associated with lesser incidence of adverse side effects compared to either monotherapy. Now, reasons for poor BP control, all of you must know. I already told you multifactorial etiology of hypertension. Monotherapy is effective only in 25% of the patients. Simply uptitrating the dose of treatment is unlikely to significantly improve response. A retrospective study of a patient with newly diagnosed hypertension suggests that excessive reliance on monotherapy was the most important factor contributing to poor control, with 40% of patients remaining on monotherapy at the end of the study. And a combination is not new. Even in late 1960s, the combination therapy concept has introduced. You can see 1960, 70, 80, 90, 2001, the combinations. Now we talk about combination, not only combination, fixed drug combination. And most of the trials, ALART study, UKP study, ABCDP, MDR study, they're using more than 2 drugs, most of the studies. And then combination, this JNC 6 panel also we saw combination should be used to reduce side effects. Even in the ESC 2018 guidelines also say ACE and ARB plus diuretic. So European Society of Cardiology and European Society of Hypertension 2018 hypertension guidelines says fixed drug combination in the initial therapy of hypertension management and 3 drugs in 1 tablet as a potential step to 2. So step 1, step 2. In the ACC guidelines, when somebody has got more than 160, 100, and when the blood pressure is more than 20 by 110 above goal, start as the initial therapy of fixed drug combination. In Canadian guidelines, FDCs in the initial therapy of hypertension management replace multiple individual pill anti-hypertensivism with FDCs. And this is the ECH European Society. 1 pill first day, the first step, initial therapy with a dual combination of ARB and CCB or diuretic. Consider monotherapy only in low risk grade 1 hypertensive or people above 80 years or frail patients. Step 2, you give triple combination, ACE, ARB, CCB, and diuretic. Step 3, you add resistant hypertension, add spironolactone with the already given single pill combination. Beta blockers are considered at any step when there is a specific indication, heart failure, angina, post-MI, or atrial fibrillation, or young women with who are planning for pregnancy. This is what I said already, fixed dose combination based protocol. Now the patient comes to you, you screen, and if there is 140, 90, you start with off tablet of telmisartan 40 and amlodipine 5 milligram as a single tablet. Use the scorable tablet. You give off tablet in the first visit. Then you give 1 tablet from first visit off tablet. Second is 1 tablet which contains 5 milligram of amlodipine and 40 milligram of telmisartan. Then third visit or fourth step, give 80 milligram of telmisartan and 10 milligram of amlodipine. And fifth step, you add chlorthalidone. And sixth step, if the patient has taken properly, adherence is there, you refer the specialist. And these are all the lifestyle modifications. And then you have to manage diabetes as a national protocol. Always aim for 130, 130/80 when they have a comorbid condition. I told you monotherapy, 75% are not amenable. 25% of the treated patients do not reach BP targets with dual drug combination. So you must escalate the dose of dual therapy or dual combination plus one drug or triple drug single combination. These are the fixed drug combination and pre-drug simplicity, compliance, efficacy, tolerability are better in single pill combination, fixed combination. And why we use chlorthalidone, amlodipine, telmisartan? BP reduction is good. Stroke MI risk reduction is good. Pleiotropic benefits, chlorthalidone, amlodipine, and telmisartan. Guidelines, recommendation, clinical experience, outcome trials. All those things prove these three drugs are good. So that's why many states use this combination of amlodipine, chlorthalidone, and telmisartan. And there are other combinations available in the market. I think all of you know it is amlodipine, telmisartan, hydrochlorothiazide, amlodipine, olmesartan, hydrochlorothiazide, cilindapine, telmisartan, chlorthalidone, cilindapine, olmesartan, chlorthalidone, amlodipine, telmisartan, chlorthalidone, amlodipine, losartan, and hydrochlorothiazide. What are the advantages and disadvantages? There must be no contraindication or caution for both drug components, higher cost, lesser ability to individualize drug titration, less ability to identify adverse drug effects. Why combination is better? What are the benefits? One, complementary mode of action, better BP reduction, lower incidence of individual drug effects, early BP goal achievement. So patients spend less time in high risk state. For example, if you achieve the blood pressure control in 9 months, and if you give single drug or drug separately, it may take 1 year. So high risk state to achieve earlier, patients spend less time in high risk state, increased target organ protection, improvement in cardiovascular outcomes, improvement in tolerability profile, lower risk of myocardial infarction, heart failure, hospitalization, and stroke, reduction in morbidity and mortality, the ideal therapy in patients with comorbidity, improvement in adherence, guidelines recommendation proven in landmark trials. That's why we give combination therapy. Now, before I conclude, I want to emphasize two important things which we normally see. In last 4 or 5 webinars, we were insisting that treatment inertia should be tackled. The treatment inertia is defined as a failure to increase the dose of medication or add another medication when patient's blood pressure is not under control. Suppose we give one drug and patient comes to you and the patient's BP is like 150, 94, we say, hello, we'll see next time. We don't increase another drug. So these are the reasons, because doctors may not notice the high BP recording due to busy, crowded clinics. A nurse or the other staff may highlight the BP reading for the doctor using color pen, highlighter, or symbol. They can say this is increased. BP readings are borderline high. The doctor suspects that the patient might have missed the medication. The nurse should ask detailed history to understand the patient's adherence. Patient might have reported adverse effects, change medication to a different class. It is difficult for a clinician to make decision with one high BP reading, or well-maintained record with multiple BP reading can help the clinical understanding and the trend of the blood pressure and make an informed decision. That is why I always promote home blood pressure monitoring. And clinical inertia can be physician factor, patient factor, or office system factor. And then adherence. I already talked one full lecture on adherence. You know what is adherence? Adherence refers to a process in which the appropriate treatment is decided after a proper discussion with the patient. What is non-adherence? Patients who exhibit an apparent lack of efficacy with their treatment, multiple adverse effects, resistant hypertension, be useful clues for healthcare reasons to suspect adherence issues. And when you see where patient has got not adherence, consider the following strategies: reducing polypharmacy pill, use single pill combination, once daily dosing over multiple doses, linking adherence behavior with the daily habits, providing adherence feedback to patients, home BP monitoring, reminder packaging of medications, empowerment-based counseling for self-management, electronic adherence aids such as mobile phones or short message services, multidisciplinary healthcare team approach like pharmacists to improve monitoring of adherence. And of course, cost about affordability. Now, chronic cases like hypertension, which require lifelong treatment, it should be easily available at affordable range. That is why in many governments, they give medicines free of cost for poor people. And in some of the states like Tamil Nadu, the healthcare team goes to the house and supplies full month medicine. This was very useful during the COVID lockdown period. So affordability can be reduced when you have bulk purchase. Let me summarize the whole thing. Simple, detailed protocol, administrative and operational procedures in place to enable task sharing, regular uninterrupted supply of medication, patient-centered service that reduce the barrier to adherence, cost reduction, convenient medical visits, and medication refill. Once daily treatment regimes, fewer tablets, including through combination medication, improving access to blood pressure monitoring, public education, an information system that allows real-time feedback on adherence and blood pressure control among individual patients, and different treatment systems to facilitate continuous BP control. 140/90 is higher cutoff for hypertension. Evidence suggests that lower blood pressure is better. Up-titrate the medication when the BP is more than 140 or diastolic is more than 90. Even if the rise is in the borderline, this or systolic diet is borderline, you can titrate and see there is no adverse effect. When adverse events occur related to antihypertensive medication, they are generally transient and without long-term health consequences. Contrast this with mortality or lifetime disability for a major stroke or heart attack. So of all adult primary care interventions, improvement in the management of hypertension treatment can save most lives. So one of the primary care interventions which everybody can do, if I already emphasized, if you are very patriotic, if you want to do something good for our country or the globe, if you control hypertension, so many disabilities can be prevented, heart attacks, kidney failure, paralysis, etc., by controlling. So prevention in your hand. So can also reduce spending on the management of patients with heart attacks, strokes, kidney failure, and other preventable complications of uncontrolled hypertension. Suppose somebody develops stroke, it's very difficult for rehabilitation. The whole family will suffer. So prevention is the key, and you are the key person to do a simplified protocol and make sure patients' BP are under control. Massive as this challenge, it can be done only if practical, specific treatment protocols are adapted, used, optimized based on actual experience. It is time to implement simple, practical, specific hypertension treatment protocols to improve blood pressure control. So my affectionate appeal to all of you is promote home blood pressure monitoring, focus on organizing hypertension clinics, because we need more hypertension specialists and hypertension clinics. And this is the Bhagavad Gita already. I already told you, control over his diet, takes regular exercise, has time to relax, has the right toil in discharge of his duties, observes proper hours of sleep and awakening, and is balanced in his actions and reactions, emotions and reasons, duties and rewards, conquers disease. So thank you for your attention. I think now I'll hand over to Bajita to conduct the Kahoot before we go for the average. Yeah, yes, Bajita, over to you.
Yeah, thank you, sir, for that excellent deliberation, not only on the simplified protocol, but also on how it helps in maintaining the adherence. So all the participants get ready for the Kahoot. We will be giving the pin shortly. So be ready to win. So this is the game pin. And as you all know, the questions are also based on the lectures which are taken. So I'm sure most of you will score very good. It's also how quickly you score, because it's not just the number of questions you get it right. It's something like a fastest finger first at KBC. So it's the same with us here. So we have 162 participants, only 33 have joined us yet. I request others also to join. Muruganathan sir, we'll wait till 50 or?
Yeah, we'll start.
We'll start. Okay. So 3, 2, 1, and we begin with the first question. How simplified protocols helps private sector provider in hypertension management? So your options are streamlined care, simplified drug procurement, improved patient adherence, all of the above. Okay, so yes, it's all of the above and almost all of you got it right. Going to the next question. So Manish is at the top at present. Initiation of pharmacological hypertension treatment should start no later than 4 weeks following diagnosis of hypertension, no later than 6 weeks following diagnosis, no later than 3 months, or no later than 2 months following diagnosis of hypertension. When should we initiate the pharmacological hypertension treatment? Okay, so the correct answer is no later than 4 weeks following diagnosis of hypertension. Okay, so we have a change now. Dr. Rekha is on the top now. Coming to the third question. According to WHO recommendation, what is the frequency of assessment in hypertension for patients with BP under control? 1 to 3 months, 3 to 6 months, 6 to 9 months, or 9 to 12 months? The frequency of assessment. And the correct answer is 3 to 6 months. Okay, we have only 18 of you who got it right. But anyway, okay, so Dr. Rekha still leads the board. Estimated proportion of people living with hypertension in India with controlled BP. Below 5%, below 15%, below 30%, or below 40%. It is the proportion with controlled BP in India. And the correct answer is below 13%. Okay, oh, sorry, 15%. Okay, now we have Dr. Hassan, who's climbed up the ladder. But anyway, we have many more questions coming. So coming to the next question. What are the recommended drug classes to be used as first-line agents for the treatment of hypertension? Thiazide and thiazide-like agents, ACE inhibitors or ARBs, long-acting dihydropyridine CCBs, or all of the above. Recommended drug classes as first-line agents. And the correct answer is yes, as Sir had said, all of the above. All of them are recommended as first line. And now the leaderboard shows. So Dr. Hassan is maintaining his top position. Going to the next question. Which of the following sentence is false about fixed drug combination? Long acting, increased side effects, can improve control rates, greater BP reduction at mid doses relative to maximum of single drugs. Which of it is false? So 3 are correct, one of it is incorrect. And the answer is it's increased side effects. Let's see, where are we now? Okay, so Dr. Hassan continues to be at the top. Question 7. In the absence of investigations, which is the antihypertensive drug of choice? Thiazide and thiazide-like agents, AC or ARBs, CCBs, all of the above. When you have not done investigations or you don't have those, so what would you start with? Which would be your drug of choice? And the correct answer is, well, okay, I thought most of us would have got it right. It's the CCB because it doesn't have much of contraindications. Okay, so Dr. Rekha is also climbing up, but Dr. Hassan continues to lead. The 8th question, how can we address the treatment inertia? Well-maintained record, proper communication between patient and physician, adopt simplified protocols, or all of the above. So treatment inertia can be addressed by, well, it's all of the above. Each of them have their importance. And okay, no change in the leaderboard. Dr. Hassan continues to be there. Coming to the 9th question. What are the impact of non-adherence to antihypertensive medications? Cardiovascular disease, kidney disease, greater healthcare cost, reduced quality of life, or all? Non-adherence impact. And the answer, which is correct, is, well, all of the above. And most of you got it correct. Okay, so we still have Dr. Hassan on the top, followed closely by Dr. Rekha and Dr. Hemant. Question 10, challenges in hypertension management, the therapeutic inertia, low patient awareness, aversion to treatment or irregular treatment because of no symptoms, poor lifestyle, the various lifestyles, diet, physical activity, tobacco, and excess alcohol, or all of them. And yes, most of you again got it right. It is all of the above. Okay, so the top positions remain the same. Coming to the next question. Question 11, in patients with diabetes mellitus, when should antihypertensive drug treatment be initiated? When systolic BP is more than or equal to 140, systolic BP more equal to 130, more equal to 150, or more than equal to 120. So systolic BP more than how much you should start antihypertensive treatment in patients having diabetes mellitus. And the correct answer is systolic BP of more than or equal to 130 mmHg. Okay, so we have, so Dr. Hassan leads. Coming to number 12, isolated systolic hypertension is common in young, elderly, pregnancy, or none of them. Important entity, ICH, is common in which of these groups? Okay, so again, most of us got it right. It is in the elderly. Okay, so now Dr. Rekha is on the top, followed by Hemant and Karthi. Dr. Karthi, sorry. 13th question, which of the following is a known side effect of ACE inhibitors? Hyperkalemia, hypercalcemia, hyperglycemia. Okay, I think there's some mistake. C and D, both are hyperglycemia. So you have to tell the known side effect of ACE inhibitors: hyperkalemia, hypercalcemia, or hyperglycemia. Yes, it is hyperkalemia. Again, most of you got it right. Okay, so this is the leaderboard position at present. The first line antihypertensive drug of choice in diabetic patients is diuretics, ACE inhibitors or ARBs, beta blockers, or CCB. So hypertensives with comorbidity of diabetes, which of these would be the antihypertensive drug of choice? Yes, the correct answer is B, that is ACE inhibitor and the ARBs. Dr. Rekha continues to be on the top. And coming to the last question, which one of the following is the safest drug for hypertension in pregnancy? ACE inhibitors, the ARBs, diuretics, or methyl dopa? Hypertension in pregnancy, the safest antihypertensive drug. And the answer is methyl dopa. Again, most of you got it right. So now let us see the final leaderboard position. Okay, so at position 3, we have Dr. Karthi. At position 2, Dr. Hemant. And at position 1, we have Dr. Rekha. So I request all three of you to send your mailing address in the chat box. The BP monitor would be provided to you. And congratulations to other participants also. Most of you answered it correct, though it took a little more time. So with that, we finish cowhood. And before we take the questions, I will first go to our esteemed panelist, Dr. Sangram, for his comments, and then we will start taking the questions. Sir, to you.
And all the
thank you.
winners, please send your courier number also, courier number and mobile number, because
Okay.
when you courier it, they need the mobile number and the PIN code number. Both are very important. Yes.
Yes. Yes, sir. Dr. Sangram, please. Sir.
Yeah, as usual, it was an excellent deliberation from Dr. Muruganathan sir. And the only thing, what is important in nowadays treatment methodology is like precision medicine. Selection of the drug itself is very important, and approach should be patient centric, because if we see 20 patients, each one of the patient will be having a different associated comorbidities, where we have to select which sort of patient, whether patient has got a hypertension with kidney disease, hypertension with diabetes, hypertension heart failure, hypertension pregnancy. So it is totally a patient-centric and cost-effective treatment, because all patients cannot afford for all telmisartan, olmesartan, because cost effectiveness is very important in our Indian setup. And drug selection is very important. Protocol guidelines, they tell for us to learn, but every patient is a different patient. Whoever is in front of us in the OPD, we have to think that patient. What are the comorbid factors? What are the associated factors? Which drug is suitable for this patient? Next patient may be, some other drug may be suitable for the next patient. So it's totally a patient-centric approach, customized and individualized therapy. So like what we think is in future days, like precision medicine, this drug is effective for this drug, sort of thing. So such sort of things should be the area of development in the hypertension. So, and of course, monitoring lifestyle modification, the one first important thing, and see the basic, cultivate the habits of examining the blood pressure, basic measures to be taken, accurate. At least once we have to record blood pressure ourselves, because most of the times we will tell all the staff nurse, junior doctors, we rely on them. So that should not happen. At least once in our lifetime, we have to see the patient blood pressure in all the 4 limbs at least once. If not in the lower limbs, at least in the upper limb, both upper limbs, supine, standing, with all the criteria. And though it is NCD is always in National Communicable Disease Eradication Program. So I think Government of India should take up this program in a big way, like providing medications. As sir told already, Telangana, Punjab protocols are different, but it should be universal. And one more thing, what is important, it should be a supervised regime, like for example, tuberculosis treatment is there, supervised therapy, leprosy. So until and unless we supervise, our patients may not be having proper tolerance or adherence to the treatment. They take it very easily. They think that tomorrow I will take, day after tomorrow I have not taken for 1 week, 2 weeks I have stopped. They will have their own experiments. So that should not happen. So it should be like a DOTS regime or whatever it is, like which program has worked up very well. So because hypertension is one of the important, so and recording of blood pressure, monitoring of blood pressure, as Dr. Muruganathan sir told, home blood pressure, ambulatory blood pressure, all those things we have to educate to the patients and our patient. Thank you.
I also take the opportunity to welcome Bhanu Pratap Singh. He is from the Resolve to Save Lives. Bhanu Pratap, welcome Bhanu Pratap. Thank you very much for...
thank you so much, Dr. Muruganathan. Thank you so much.
And Bhanu Pratap is from the Resolve to Save Lives. And this Resolve to Save Lives, Sangram brother, they do a lot of monitoring. And they are the active partners in the Indian Hypertensive Control Initiative. And they are trying in various states. And the Simplified protocols, what they follow, really yielded a very good result. I showed you a slide where people who are taking nearly 45 to 50% of the people under control. Never in the history we had that much control. When we followed a system with this protocol, we are very proud to say that control is good. That is why we are propagating, and we thank Bhanu and Anupam, and who are all the active partners in Resolve to Save Lives for introducing this protocol and implementing in all states. Every state, we go. Recently, we went to Mumbai Corporation, where they followed a simplified protocols, not only for hypertension, they also doing simplified protocols for diabetes also. Over to you, Vidita, please.
Okay, just to add, Dr. Bhanu, have you come to Sikkim also? Are you doing your activities in Sikkim?
I haven't been to Sikkim as of now.
Okay, yeah.
My team would
Okay.
would have been.
Okay, okay. No,
But
because
Birita is
yeah.
like this, Birita. When we do simplified protocol, the state government should invite us. The Indian Indian Hypertension Control Initiative is from the central government, state government, ICMR, WHO, Resolve to Save Lives. And if state government invites us, what we do, the team will come and invite the state professors and state learned people, and we do a brainstorming and discuss what is suitable for that particular state, and then we come to a conclusion. It can be amlodipine, telmisartan. Some people will take amlodipine, ACE inhibitor. It depends, And
yes, sir, because
yes.
When
So
you were
said,
talking, because here what happens, sir, as you all are aware, there is this idiopathic leg swelling, leg edema, which occurs at high altitude.
Okay.
There's no cause for it, and it is not even known it's idiopathic. So though here also amlodipine is started as the first line, and that is the only drug which is available free of cost in the government hospital. But then the leg edema is there otherwise also. And then with amlodipine, little amount of leg edema. So many people, we have to then change over to another drug. So that is there. Okay, so I will look into it. I will find out from the state, and we will take the opportunity of inviting you all.
Your state health secretary knows about this initiative, and once it's there, all our people, experts will come, and depending on the state culture, the availability of drugs, they can always, change the protocol. It is not fixed protocol for every state. Yes.
So I'll take
Banu,
the question.
would you like to answer something? Banu, would you want to say something? Banu Pratap?
No, I think you have covered it well, Dr. Mohan.
Okay, fine. Okay,
so I'll take the questions. So the questions are of course, for our learned speaker. But so anytime, Dr. Sangram, when you feel you want to come in and add something, please add. Okay. So coming with Dr. Yogesh, he says that digital BP instruments are recommended in many webinars, but it needs to be calibrated every year. So what does he do with his mercury sphygmomanometer? Does he throws it off?
No, actually now the whole world now, doesn't like mercury manometer. You can keep it as only standardizing, comparing the digital manometer. And digital manometers, there is two difference, calibration and validation. When you buy a machine, it is validated and you are using it. And calibration you have to do once a year. So it's always better to buy a good standard machine which is validated. And sometimes these validated machines are useful for 1 year. And if you want calibration, the same company can do the calibration and give you the calibration and then approve your monitor.
Okay, Dr. Amod has 2 questions, sir, for you. What and where is the role of alpha blockers, ARNIs and MRAs? And any special advantage of the newer CCBs like cilnidipine, benidipine, etc. over amlodipine?
In fact, the amlodipine has gone under many trials, and now it is well proved, very good drug. The important thing in the public health sector, and when you use a simplified protocol, it should be cost effective. See, amlodipine is very cheap, and then it is well known. It is known everywhere. Under the trials, clinical outcome trials, everything is proved beyond doubt. That is why we prefer calcium channel blocker amlodipine. If somebody can afford, and if somebody wants to change the drug, they can always do. But overall, you must think lifelong. One has to take the treatment. Even middle class people, if you give a little costly drug, they may take for a year or 2. If you see the complaints, the adherence, the ARBs are most, good drug. People take at least once at least up to 1 year. So that's why we don't give any newer drugs. Of course, alpha blocker, the question is, we can give in a patient with prostate enlargement, and when there is resistant hypertension, when there is no other drug, we use the alpha blocker as the 4th drug or 5th line drug. And mineralocorticoid MRA agonist like spironolactone definitely will be useful in resistant hypertension. When you have a secondary hypertension, when you have a resistant hypertension, when you have sleep apnea, these drugs will be very useful.
Okay, so coming to questions by Dr. Rangarajan. A patient who is normotensive, having albuminuria, no UTI or infection. Now, if you put him on ARBs, BP would fall. So how do you treat his albuminuria? So basically, normotensive patient with albuminuria, giving ARB, and if there's a fall in BP.
Actually, when you have a albuminuria, you will have to assess the other things. Why the albuminuria is the chronic kidney disease? There are some studies, they said even with normotensive ACE inhibitor, for example, ramipril 2.5 milligram can be given for a albuminuria case, not to reduce hypertension, to prevent further damage to the kidney. So there are a lot of studies, but in practical experience, when somebody has got albuminuria that much, they definitely will be little more hypertensive. And you can start titrate the dose. You should always monitor potassium. You should also monitor the electrolytes when you have such kidney issues.
So, sir, ramipril 2.5 would not cause fall in BP, but can be helpful in treating albuminuria.
Yes.
But as you said, if the person is not hypertensive, we should look for other causes.
Yes.
Yeah.
Can I add one point?
Yes, sir. Please, sir.
Yeah. In fact, Dr. M.K. Mani from Chennai used to tell for all albuminuria, even enalapril 2.5 milligram is sufficient. So that will not produce hypotension, or if you go on building up the doses of enalapril also, you don't bother of hypotension, because they are drastic fall of blood pressure will not be there. Reversal of albuminuria is important rather than this thing.
Okay, sir. Dr. Rangarajan also asked that of the diuretic combination with ARB, hydrochlorothalidone or hydrochlorothiazide or chlorothalidone, which you would choose and why?
So I already told you, chlorothalidone is better than hydrochlorothiazide.
Yeah.
Nowadays, all guidelines recommend only chlorothalidone. It has got long-acting action, plus it has got pleomorphic action. It also produces vascular dilatation, and the diuretic part is only initial. So it has got a lot of pleomorphic effect and long-acting effect. So we prefer chlorothalidone, and most of the guidelines also recommend chlorothalidone.
Dr. Mohan is asking, so what should be the time of the day when CCB or AC inhibitors or ARBs should be given?
Again, I told you the telmisartan, amlodipine have got 24 hours action. So it all depends on your convenience. Somebody wants to start the drug, give the drug in the morning, give both the drugs together. Or if somebody wants to give in the night, they can give again a customized way. But that is why we give drug combination of amlodipine and telmisartan can be given in the morning or night, because it has got both 24 hours action. So there is no need to debate whether to give the night or the day. There are a lot of studies like Maple study and studies where you give the drugs in the night and nocturnal hypertension can be controlled. But logically, when somebody drug has got 24 hours action, you can start in the morning or night. Doesn't matter. Again, the key is if you give fixed drug combination, side effects are less, the BP control is less, monitoring is better.
And so if diuretic is added, then we prefer in the morning?
Yes, if you add diuretic you can
prefer in the morning.
Yes.
In what situation or BP levels is amlodipine 2.5 or a ARB of, okay, ARB 20 is given in many. I think Dr. Rangarajan mainly wants to ask about amlodipine 2.5.
Yeah, in a single, especially when the hypertension is mild, like, their blood pressure is less, systolic is 140 to 144, and diastolic is only 90. And you observe for some more time with lifestyle modification, if there is no improvement, and lower is better. Even there are studies when people with 140, if you reduce to 130, the cardiac events are reduced. So in those cases where you call borderline hypertension, the inertia should not be there. You should put them on 2.5, no harm. Yes.
So we had a question on isolated systolic hypertension. Dr. Rangarajan wants to know about isolated diastolic hypertension and what drug should be advised there.
See, isolated diastolic hypertension, usually you see in younger age, below 50 years. And ACE and ARB should be okay. And you see the other comorbidities, other situations, then you decide. But usually, isolated diastolic hypertension is quite rare when elderly, only in younger people. Isolated diastolic hypertension or diastolic hypertension per se can come in a elder age group in a secondary hypertension, where there is a renal problem. You may get diastolic hypertension. Then, depending on the secondary cause, you have to treat the cause.
Treat that. Okay, so we have many more questions from Dr. Rangarajan. We will take those. Hypertension occurs following treatment. BP has become 80/60. What to do? How do you manage?
Actually, then that means you are not titrating the dose properly, and you will have to go stepwise. What was the initial blood pressure, and is there any comorbidity? Have you done 24 hours BP monitoring? Because one reading of low hypertension it doesn't give any clue. But initially, what was the blood pressure and what was the dose you started? And if the patient continues to have this much, you can do de-escalation and observe. But whatever you do, when you reduce the dose, when you do de-escalate, you have to monitor before you do that.
And so for below 18 years of age, what is the normal BP?
Again, it's a pediatric question. There is always a percentile BP, they say. 90% of the percentile BP you should have, like that. So again, depends on the target and the range you'll have to do in the pediatric patient.
And so do we have any sick day rules for hypertension management? Sick day rules. I think what Dr. Rangarajan is meaning that we have those sick day leaves, no sir, for diabetes, for stroke.
I don't think any non-communicable disease has got sick day rule, because you've got so many non-communicable diseases like obesity, hypertension, diabetes,
metabolic syndrome.
Yeah, metabolic syndrome. So if everybody is given a 6-day leave, and everybody will come into that picture of that 6-day leave, only when they have a complication, for example, hypertension with kidney failure, heart failure, or stroke, then definitely sick leave can be there. When somebody has got hypertension without any symptoms, there is no justification. Of course, if you have a hypertension emergency, you can say so-and-so is there, so we can get even the benign hypertension where there is no target damage, it can be treated outpatient. So I think sick leave may not come. I think Rangarajan is
okay.
not a government servant. I don't know why he's asking all this.
No, I think sir has answered, but Dr. Rangarajan, if there's anything else you would like to add to it, you can again post, we'll take it up. Now coming to Dr. Bhattacharjee, he's asking, sir, when to use aspirin as a primary prevention for ASCVD in hypertensive patient, and is there any increased risk of ICH in uncontrolled hypertensive patient?
In fact, aspirin has no role for primary prevention. Normally, aspirin is given only for secondary prevention. There is a lot of debate going on whether aspirin can be given as a primary prevention. No. Now people say not necessary, don't give aspirin, because the risk and the benefits ratio is not good for aspirin as a primary prevention. It's only given for secondary prevention. The second question is like intracerebral hemorrhage.
Yeah, means if a patient has uncontrolled hypertension, is there increased risk of ICH? I think what Dr. Bhattacharjee means to ask is that if aspirin is given in these patients, because uncontrolled hypertension, we all know, is an increased risk for ICH. So with use of aspirin, does that risk increases?
Definitely. That's why I said in hypertension, for primary prevention, we don't give aspirin. You should not allow uncontrolled hypertension to lead on to target organ damage. So that is why you allow to be aggressive and do combination therapy, monitor and reduce the blood pressure so that you can prevent stroke.
Dr. Agarwal asked, in hypertension with nephropathy, what should be the cutoff value for serum creatinine?
Again, now we talk about serum creatinine and eGFR.
Yes,
and so we always monitor eGFR along with creatinine. And if the most of the drugs like ACE and ARB, usually people ask whether we can give. We can give ACE and ARB even up to the age of, even if the eGFR is below 40. Up to 30 we can give. And if somebody is under control with the blood pressure, the main thing is to control the blood pressure and also monitor eGFR. Depending on the individual case, we can tackle, because the more and more pressure, the more and more intraglobal pressure, and then kidney failure will be more, and then problem will be more. So control the pressure plus monitor eGFR and creatinine and potassium.
Dr. Sangram, you want to add something? I think sir has answered. You want to add something to this?
Yeah, Dr. Rajshekhar has done a lot of this thing. Rajshekhar's comment on this.
Rajshekhar, sir? Okay, I think sir's not there.
Now, nowadays you have got better modality of assessing eGFR. So many apps are there. It's quite easy, comfortable, handy. So always better to get an eGFR and start the delivery treatment. That will be an ideal one.
There are six formulae to calculate EGFR. That is Cockcroft C2, A2, M2. One is first C is Cockcroft-Gault formula, which we follow very easily. 140 minus age into weight divided by serum creatinine into 72. That is EGFR. That is CK formula. If you multiply it to 0.8, that gives the female. Another is chronic epidemiological kidney disease formula. Another is age-related formula. One is Schwartz for children. Another age-related formula is Prabhat Agarwal formula. That is 30 to 40, 41 to 50, above 51. That is how we have to calculate. That is Prabhat Agarwal formula. That is, he is the professor of medicine from SNI Medical College. 2 years back, he has formulated it.
Okay, coming to other few questions by an anonymous attendee. The similar question as was for CCB, for AC inhibitors, newer ones versus the older ones, your opinion?
Actually, compared to ARB, there are no new AC inhibitors. See, you can see so many ARBs coming in the market. Kindly unmute, can you mute, please? Can you mute, please? Mute all. Actually,
request, yeah.
Yeah, I'm requesting. Yeah. So there are, if you see the pharmacology market, there are no new ACE inhibitors. There are more of ARBs only. You can see every day ARBs are coming, but not many ACE inhibitors are coming. Your question is
Perindopril. He's talking about perindopril versus enalapril and ramipril.
In fact, enalapril is a good drug. Unfortunately, it is not available now in India. Enalapril is good drug.
Megha, can you mute other people?
Yeah. Okay. So, in cardiovascular outcome study, people still believe ACE inhibitor is better than ARB. But after the on-target trial, they proved that telmisartan is non-inferior to ACE inhibitor ramipril. So now they use both ACE and ARB. And I don't know, now market is not that much for ACE inhibitor. They are only ARBs or more.
He also adds, of course, it's a comment that yes, hyponatremia is an important and relatively common side effect for all diuretics, including indapamide. So we should be careful while using in elderly. Okay. Dr. Parvesh is asking, sir, what should be the drug of antihypertensive in patients with hypothyroidism? Anything specific for hypothyroidism?
Only thing, when a patient with hypothyroidism, already he'll be edematous. So you can avoid calcium channel blocker. And, you can use the other drugs as per the age and as per the comorbidity.
For hyperthyroidism, of course, beta blockers are given to take care of the
again hyperthyroidism also.
For hyper.
The hyper also, you don't give amlodipine because tachycardia will be there. So you can give you can avoid this.
Yeah, beta blockers can be actually used. The anonymous attendee also asked how azilsartan is different from the other sartans. Alpha blockers we have already mentioned. Causes of secondary hypertension we had taken in our previous lectures, so I think we will not take that today. The first question we can take, azilsartan different from other sartans?
Actually, azilsartan, people claims that the drug dissociation is long and it is very good for diabetic hypertension. The duration is good, but in practice we see telmisartan always scores over azilsartan because it is now there are so many trials have been done and cost effective also. Azilsartan is a new drug. It is also good. There are not much difference between telmisartan and azilsartan, except telmisartan has got a dual action of PPR gamma activity, and azilsartan says the drug dissociation takes long and it's supposed to be long acting. It is good for diabetic hypertension, they claim. So practically telmisartan is always the drug which is right and which is cheaper and can be used.
Sir, Dr. Mohammed is, because we were talking of cost effectiveness, so he says amlodipine and nifedipine both are very widely used and both are cost effective. So any one benefits over the other one?
Not all. Actually, somebody is.
I don't know. There's a echo coming from your voice.
Now is it okay?
Yeah, it's okay now, sir.
No, somebody else is.
No.
Rajshekhar, can you mute? Please?
Yeah.
Rajshekhar, can you mute?
The host is muting me.
Okay.
Dr. Rashekar, yeah.
Can you mute Rashekar? Yes. Okay.
Yes, sir. Please ask your host to unmute and start the video.
Yeah.
Okay, so it was
what-
amlodipine and nifedipine.
Azilsartan angioedema is very rare. That is one advantage of azilsartan.
Okay. Okay, that was azilsartan versus.
Actually, Birita, now people are asking all sorts of questions on hypertension. Actually,
I know, yeah. I think, yeah, we'll have to draw a line somewhere. But anyway, sir, I'll just quickly. So people want to know from where can they get the recording of the ones which they have missed, or also of.
yeah,
today?
it is in Facebook. I think we will put it in the WhatsApp group. Immediately after the program, we'll put the link. Not only this webinar, all the 7 webinars earlier also, it is available in Facebook, and also we can send it.
Yeah. There is one interesting question. I'll also answer that again from the anonymous attendee. Any justification in giving antihypertensives on alternate day? So, well, as far as I know, there is no justification. It is daily dose. So your take, and Dr. Sangram's.
Since it is telmisartan is they are all long acting, so
Yes,
preferably sometimes the people practice of habit alternate day they will take because of that advantage they want to have. Whereas in other like beta blockers, this thing and all short acting, it is difficult.
See, regarding olmesartan and telmisartan. Telmisartan is least important.
And telmisartan another advantage. PPR gamma already has told.
PPR gamma already has told.
Okay, I think there is a problem with Rajshekar sir's.
Rajshekar, I think you have to switch off one more device.
Yeah,
I think
sir
you have
is
got
on
2
2.
devices.
Yes,
I think you have got 2 devices, Rajshekar, please.
So it's echoing actually. One is echoing from the other. And of course, as you said, sir, to our participants also, we appreciate your questions, but we've been actually talking about all this, and we'll also be talking about the various other questions which you all have posted in the subsequent webinars. But today, since we were sticking on to the simplified protocols, so we are not taking the other questions as of now. And so, yeah, Rajshekar sir, you were saying something. Maybe now with one you
Sir,
can. Yeah.
one question important. When
Yes,
you
sir.
take drug, if you go through the authority of Norman Kaplan, the hypertension, he used to say, whenever the patient gets up in the morning, even he gets up in the early morning to pass urine, he must take that time, that antihypertensive. That's what he's saying. And another thing is nocturnal hypertension, dipping, according to dipping, you can add one more drug. So according to the dipping pattern, you can add. Instead of increasing one drug to have adverse effects, better to combine 2 drugs to prevent adverse effect of a single drug. That is very important.
Yes, that was mentioned, of course. Okay, so I'll go to Dr. Sangram again. Sir, your comments.
Birita, there are any questions like, even if it is a general hypertension question, doesn't matter. 1 or 2 questions you can ask, there's no problem. We are all ready for answering any question, but I just want to be specific on this. But anyway, if there are any interesting questions, don't worry, you can ask, there's no problem, because I'm supposed to know about.
Okay, so yeah, this question I think we'll take. Dr. Mukesh is asking, a patient is on a triple combination of amlodipine, telmisartan, and chlorthalidone, and is well controlled with it, but has pedal edema. So how do you manage?
Actually, the pedal edema, if there is no organic cause, there is no organic cause, it is only cosmetic purpose. We can, give them lifestyle modification, like when he stands up too long, and the dependent edema will be there. When he lies down, the edema may go. And when you give chlorthalidone and telmisartan and amlodipine, if somebody has got edema, then we have to rule out the other causes why it has got edema. Maybe anasarca, hypoproteinemia, or liver. All those things, if you rule out, And if everything is under control, and if it is not bothering, I think if the edema is not associated with breathlessness, things like that, I think we can monitor and see.
And reassure the patient.
Yes.
Sir, Dr. Mohammed says that though methyl-topa is the drug of choice, but in his area, it is mostly nifedipine and labetalol, which is being used in hypertension in pregnancy. So your comments on it?
Yeah, actually nowadays we don't use methyl-dopa, we use labetalol only. And nifedipine can be used as a long-acting nifedipine only as a oral drug, not sublingual. Very important thing, nifedipine should not be used sublingually. A long-acting nifedipine can be used in pregnancy if there is still resistance. You start with labetalol, and if still there is no improvement, then as a second-line drug, nifedipine orally long-acting can be given.
And so using
sublingual nifedipine is to be avoided.
Not to be given.
Causes severe hypertension. Nifedipine is the most potent antihypertensive drug. Still, it is being supplied by all government hospitals. If the patients are very well controlled, I don't change. Patient's pedal edema, as Sir said, if it is not due to organic, no problem. We can advise the patients to continue the same.
And so, is there any advantage of the S isomer, that is the S-amlodipine or S-metoprolol, over?
Honestly, there is no advantage except for the company.
Yeah, racemic mixture. That is S isomer or isomer. Once upon a time, it was told that S amlodipine and a racemic mixture, yes, isomer is better. But as far as after the advent of drug and the release of utilizing, it is no advantage.
And so
still patient has got reflex tachycardia and pedal.
So for patients,
some people have asked calcium channel blockers the advantage. LNT, that is 3 channels.
3 channels.
Just to remember late, LATE. Just remember L channel is on the afferent arterioles. Next is T channel in the efferent arterioles. So easy to remember. N channel are neural receptors. So only drug which has got a triple channel is beridipine. Whereas the other cilnidipine, azilipine, all those drugs are only dual channel calcium channel blocker. For example, azilipine has got a L and T, whereas cilnidipine is L and N channel blocker. So one has got an advantage, another has got a disadvantage. We must modulate accordingly. After all, only there are about 8 to 10 drugs for diabetes and hypertension. Only permutation combination, that's all. That is what the famous Canadian cardiologist Gabriel Kahn used to tell. It is 100%.
For patients more than 60 years, some guidelines, they say that you should control hypertension only if the SBP is more than 150 and not 140. So
actually, no, we don't go with chronological age. We go with biological age. If somebody who's got 80 and still active, they are not considered as the very good person. Their BP can be 140. If somebody who's got 80 and frail, then we know we should not reduce. They can go up to octogenarian 150. But all said and done, for all 60 people, the definition is still 140 only, 140, and depends on the comorbidity, frailty, and their mobility. And as I said, we go with biological age than the chronological age.
And so does AC inhibitors have pleiotropic effects like the ARBs?
Yeah, in fact, ACE inhibitors are more having good effect. That is why cardiovascular mortality and their outcomes trials are all done by ACE inhibitor only. ARB is also now equally good as after one on-target trial. They use now ARB instead of ACE inhibitor because of the less angioedema, less cough, dry cough, etc.
And of course, when is minoxidil used? Of course, I think a full lecture on resistant hypertension will require.
Yeah, minoxidil. If you are bald, I jovially say, if you are bald,
yes, bald.
and if the hypertension is not controlled, try minoxidil, you may have hair growth for the baldness.
It's a centrally acting.
Centrally. So there are a few people who have requested, they've sent their number and they have requested you to add them in the WhatsApp group. So I think Megha must be keeping a record.
Rasher, please add them, Rasher, all in our WhatsApp group.
And provide the Facebook group name, please, also as a request.
I think we will request the, we'll put the Facebook recording link now only. we'll put it in the chat box.
Yeah. So with that,
Facebook.
It was a real good deliberation followed by a whole lot of discussion, and I think it can go on and on as usually happens with all these webinars.
But still 120 people are there, Vidita. So
yes, sir. So that is the when I said we have master teachers who speak from their experience rather than speaking from textbook. This is what happens. This is magic, sir. So, Dr. Sangram, concluding remarks from your side?
Yeah, protocols, guidelines, they are all for the sake of learning. They are all learning curves, advising and all. But practice is totally individualized, patient-centric. So
Yes,
we
sir.
have to follow the guidelines, then the protocols, but we have simultaneously see the patient who is sitting in front of you, which drug is suitable for him, whether it is a protocol guided or a whatever may be, which drug is going to help the patient. We should see that patient should be benefited. That is my
Yes,
view.
sir.
Thank you.
Sir Murunathan, sir, from your side, anything?
we'll ask Rajshekar anything. Rajshekar wants to
Rajshekar,
say.
sir, I
Losartan.
think.
One doctor has asked about losartan.
Yeah, what is the question, Rajshekar? I'll answer.
No, losartan versus other sartans.
Okay, losartan is
Other
very good.
sartans.
Losartan is very good when the patient has got gout or uric acid. Hyperuricemia,
hyperuricemia.
losartan is good. And LVH, also losartan is good. But only thing is, it should be given twice a day. Because I see, even in UK, prescriptions, they give losartan. Recently, one of my friends came. He was given losartan once a day. I told him, no, losartan is twice a day. And they are giving losartan in the UK. And they give it for LVH as well as hyperuricemia. Losartan is supposed to be good. And this is not a class effect. Only losartan, ARB, we have got a hyperuricemia, reduced uric acid reducing effect. Yeah.
Rajshekar, sir, anything else from your side?
Okay.
Okay,
Banu Pratap,
Yeah.
are you there? Banu Pratap?
Yeah, he's there. Yeah.
Yeah, I'm here, doctor.
Yeah, anything you want to convey?
And I just wanted to thank you for the wonderful webinar which you have done, and it's been a great learning for all of us. And I also wanted to thank Dr. Vidita, Dr. Rajshekar, Dr. Sangram, for their insights and valuable contribution and knowledge and expert knowledge which they have shared with us. And I think that that's a great learning for all of us, and we look forward to have such wonderful webinars going ahead. Yeah, thank you so much.
Yeah.
Okay. From
my side, Vidita, I would like to drive home the message like combination therapy is the now game changer in hypertension. Even when somebody comes first time, you can give half tablet of combination of amlodipine telmisartan. That's why combination is the key. In many guidelines, they recommend combination therapy. And European guidelines also gives, only 3 steps. First, second, third, like that. They gave 3 drugs also as a combination therapy. So that's one message. The second message, please also follow the patients with very good follow-up. The adherence is the key. Most of the problems are due to adherence. 50% of the hypertension problems is due to adherence. Spend some time, ask for adherence. Then third is the inertia. Doctors should not have inertia. Don't think about borderline hypertension. Now we have got enough more studies. Somebody has got 115 by 70, and if the BP is going by 20, that the cardiovascular events and the risk are double. So lower is the better when the patient can tolerate. And not diastolic blood pressure more than, less than 70, but the systolic at least you can always keep it around 120 to 130. So inertia should be avoided. So inertia to be avoided, adherence to be followed, combination therapy should be given, and home blood pressure monitoring to be promoted. Focus on hypertension, which is the major killer in our country. As I told you. So everybody should screen the patients when they come for any checkup. Even if they come for a little finger pain or running nose or headache or fever, opportunity screening. You must screen. I always say, not only you screen the patient, screen the attender also. And then you maintain a record registry. And why we are talking about simplified protocol, of course, individualized, Sangram brother was saying something. I didn't want to contradict him. the precision medicine, artificial intelligence, everything is there. But in a public sector, in a major sectors, when you do in the primary health sector and when you do private practice, you cannot do that. That is why we call that simplified protocols. Sangram is up to date because you would have read my article on my MediBeats, which I wrote on precision medicine this week, which I said precision medicine is very good for hypertension, but it is for individual when there is a problem. For a general public, you should follow some protocols. And in a town like this, for example, in Sikkim, this is the drug which you are using. It's a clue to the private practitioner. In everybody buys the same drug, and if the drug is there, the volume, the cost is effective. That is why we are promoting simplified protocols all over the world. And no doubt, patient-centric. Most of the patients will be amenable to our treatment. If there is any different, we can always customize. But now the teaching is you follow some protocols, and then protocols suitable to your state, and you can always talk to your colleagues and arrive at conclusion, so that the whole team can do a team-based protocol, which is good for those particular public. That's why we want to promote this. That is why government is promoting. In a government setup, when there is 220 crores of people suffering from hypertension, we cannot do individualized, and it will be a confusion. The primary health center people have got so many problems, not only hypertension, so many things. That is why we are introducing simplified protocols for the public health sector, and that is why we promote everywhere. And most of the states have taken this as a big subject. And now we are doing, Banu, how many districts we are doing in the Indian Hypertension Initiative? Banu? Around? How many districts we are following this state protocol? I mean,
so we have implemented the state protocol in around 22 states.
22 states. And all the states, not taken fully, but every state has taken 10 districts, 20 districts. Yes. So once it is successful, all the countries, whole country will be implemented with simplified protocols. Maybe 10% may require some variation, but overall the control rate will be good. Now that a control rate is less than 12. So imagine if you have a control rate of 40, 50, you can prevent so many disabilities, economic burden. That is why we are promoting protocols, not only here, all over the world. I went and spoke in China as a representative of WHO in China. I was surprised to see only 8% they are following. And then they also now started following the protocol. I spoke in Japan. I spoke in Malaysia. I spoke in Sri Lanka. So everybody is now taking up this simplified protocol for the simple reason it can be easily implemented at the public health level. So individually, when you come, you will have to have your own way of doing it. But it's overall, the district, in the town, in Kumbakonam, Rajshekhar derived something, the whole physicians can follow and then have a common problem. Like that only we can do. Of course, now we have got precision medicine, artificial intelligence, all there for all different cases of genetics and monogenic things like that. We have got multi-omics into the picture, precision medicine. That is a big area.
Yes,
I'm really doing so many readings on that. That's why I wrote an article. This MediBeats, my editorial is on precision medicine. Okay, so thank you, Vidita.
Okay, it was a privilege for me to share stage with learned people like you, Dr. Sangram, Dr. Rajshekhar, and many other eminent physicians and doctors who had joined. So thank you for giving me this opportunity. It was my pleasure, and good night.
Yeah, belated Teachers Day.
Yes.
In fact, a teacher always never stop learning, never stop teaching, never stop training. So if you are learning, you will be a good teacher. If you are teaching, you will be a learner. So listen to learn, learn to listen. So thank you very much, all of you. And those award winners, please send your courier address. We will note down. Otherwise, you can send it to me. We will send the BP monitors. And next week, same time, 9 o'clock, we are going to talk on resistance. This is difficult to treat hypertension. So I request all of you to join. Thank you very much once again. All of you.
So there have been many more requests. I think people have known of our WhatsApp group and how much we discussed there. So there are many other requests in the many phone numbers there to add them into the WhatsApp group.
Rajshekhar, can you kindly note down, Rajshekhar? Rajshekhar.
Many numbers have been posted there, sir, including from, we have a doctor from New Zealand also who has posted and has requested to share, to add them.
Yeah, actually, Binita, there are
Yeah.
at least 10 people from US. In
Mhm.
fact, Sangram Prada's a good friend from Kulkarni, he's from, logging in from US. And
Okay.
people from Australia, people from New Zealand,
New Zealand,
Muscat,
yeah.
everybody will be there, to
Yeah,
log in.
so,
Yes. Thank you so
okay,
much
so
for
thank
all your
you.
support. Yes.
Thank you. Good night.
Good night.
Thank you,
Good
sir.
night.
Thank you. Good night. Thank you,
Good
Governor.
night.
Thank you, everyone.
Good night. Good night, Bhanu
Thank you.
Pratap. Good night,
Good night,
Binita.
sir.
Good night,
Good
Rakesh. Good night,
night.
Sangram. Bye.
Good night, sir. Good night.
Still 100 people are there. Thanks for all your interest. Thank
Love
you.
and affection and
Thank you.
learning.
Thank you.
Thank you, sir. Thank you.
No end for learning.